We wanted to get started. I assume we're going to continue to get additional participants coming in, but we wanted to try and stay on schedule. Let me introduce myself. I am Bob Sharp. I'm CEO of the Florida Council for Community Mental Health and one of the organizations hosting this event. Good afternoon and welcome to the first Mental Health and Addictions Disorder Science Summit. It's something we've been wanting to do for some time, and this year seemed like a good year to do it with what's going on in Tallahassee. I'm glad that you took time. Come this afternoon, and I hope it's a good learning opportunity for you. We have some really expert speakers that know as much as anybody in the nation about the science of these disorders and the treatments that are available to individuals and the return that we get for investing in these services. First, I'd like to thank our partners for this event, the Florida Alcohol and Drug Abuse Association, the Florida Psychiatric Society, Disability Rights Florida, Florida Partners in Crisis, and NAMI Florida. And they've provided recommendations and worked in organizing this event. I want to especially recognize Judy Evans, who is CEO of NAMI Florida, for helping to underwrite the cost of the summit. I think she may have told me not to say that. Could all the partners stand up for a second so that they can see you? And these are the people who made it happen. I wanted to announce, and you may have seen it on the agenda, that we had a last-minute change. Gail Hutchings, who just recently completed a very thorough study for the Florida Council and the Department of Children and Families on the science behind brain disorders, really a meta-analysis on all of the proof of evidence-based practices that are being used to treat people with these disorders and the evidence that we have about return on investments in a variety of programs. I think it's being made available here today, so you'll have that. We also are making available the slide presentations. They'll be on our website. You'll have copies of 2 or 3 of them, and we'll make the other one available to you. But Gail took ill, like everybody's getting something. Tallahassee had just swept through here, but she just literally was too sick to get on an airplane. She's resides in Alexandria, Virginia, so she can't do that. And our facilitator, Dr. David Shuren, which is something that you can always count on him doing, is to fill in and help out when we're in a bind, and he's agreed to do that again. So thank you, David, for doing that. Now I'd like to introduce Dr. David Shuren. He's going to serve as a facilitator, and that was going to be his only role, but as I said, he's a speaker now too. And he's going to help try and weave things together from presentation to presentation, and there's no one better to do that. David is president and CEO of the National Mental Health Association. He's done that for some time. He's a Floridian that went to Virginia to do that job, and he has done many great things for Mental Health America and on the national stage, and it seems like he gets interviewed daily. He's traveling a lot, so maybe at some point we're going to get him back in Florida again. Mental Health America is the country's leading nonprofit association dedicated to helping all people live mentally healthier lives. With more than 30 years of distinguished service in mental health services research and system reform, Dr. Shuren is one of the leading mental health experts. During his career, he helped re-engineer mental health care systems in Colorado, New York, and Florida, as well as participate in several national reform and research demonstration efforts. Prior to joining what was then named the National Mental Health Association in 2006, Dr. Shuren served as dean, and for many years, dean of the Louis Delapard Florida Mental Health Institute at the University of South Florida. Dr. Shuren writes. He's authored more than 100 publications, including papers in the peer-reviewed Health Affairs, Psychiatric Services, Medical Care Health Services Research, and a variety of other publications. In 2000, he was appointed to the Florida Commission on Mental Health and Substance Abuse and served as the chair of that effort, and they really did some landmark work, that commission. I had the privilege of serving on it as well. Dr. Shern has testified before several congressional hearings and made presentations on issues from suicide in the elderly, parity, juvenile delinquency, wellness, and the connection between physical care and behavioral care. Shern was the founding director of the National Center for the Study of Issues in Public Mental Health, funded by the National Institutes for Mental Health. And he has received several honors here in Florida and nationally for creating a better understanding of mental health issues in this country. I can't think of anyone better to lead this first Mental Health and Addictions Disorder Summit that we have in Florida. We hope it's something that we do on a continuing basis each year. It's like this week we're celebrating our 6th Behavioral Health Day, and when we had our first, we weren't sure that we were going to get to the second, but we are at the 6th. And, you know, I think to the extent that we can educate the public and policymakers and stakeholders about these disorders and the science that is evolving at really a very rapid rate, and how we're applying that to practice is important for people to know, because funding is always an issue for these services, and we've got to make sure that people understand putting money in these services pays off on those people who rely on these systems for recovery and for leading active, productive lives. Thank you very much. I hope you enjoy the program today. There's going to be refreshments sometime, and and we're going to go to 4 o'clock. Thanks for coming today.
Thanks, Bob. It's great to be back in Florida and seeing so many of my old friends, remembering things like the Florida Commission and the struggles. I have to admit, you know, our public relations department wrote that introduction, and so when he said re-engineering mental health systems in List, Florida, I had to cringe. Now, it's, when I'm in Virginia or Washington State or something, that works well, but when I'm here in Florida, I guess with people who actually know about what we've tried to do with the mental health system in Florida, it's as you all know, it's a sobering and ongoing work, a work in progress. And I think we'll see today, you know, as John, Brian, and I were going through Gail's slide set, trying to get me up to steam on the points that Gail had put together. There are some definitely recurring themes around the importance of mental health and addiction issues across the full range of human service settings. You know, I've come to believe that that perhaps the greatest contribution we can make to the public's health is through systematically implementing prevention, early identification, and treatment. And we're talking about the disorders that are the most disabling health conditions, period. A third of all disability related to illness in the United States is related to mental health and addiction disorders. They start in adolescence. We're still terrible at getting people services right away, so many people become disabled or their occupational achievement is undermined by social emotional problems. And as you'll see through these presentations, we're talking about some very fundamentally important issues in our human capital as a nation. And so our challenge is to continue to educate people about those issues. Another challenge I think that we have, which is very much related to that, is closing this gap between what we know and what we do. And evidence-based practices that are routinely available to everyone in the United States. I often tell the story about my own nephew who has bipolar illness in Colorado, who I was unable, he needed a multisystemic therapy, an MST program. And even though I knew the commissioner of mental health, the person who ran the mental health system in Pueblo, the person who ran the value options, the managed behavioral health, I knew all of those people. I couldn't get Kyle what he needed and he had to go and spend a year at a residential program in Utah, involuntarily moved there by two burly male social workers who showed up in the middle of the night, and we tricked him into staying home one night. And he's doing well, thank God, but it's because my sister and our family could put up $60,000 to pay for that care, and not everybody has a house they can remortgage to get that kind of money. And because he had terrific, I think, social support as well. I couldn't get my own nephew. I was the dean of the Florida Mental Health Institute. I mean, we had the people who designed the Systems of Care Initiative, literally, and I couldn't get my own nephew what he needed for his care. And so it just strikes me that if I can't get my nephew what he needs, and it was because it wasn't available, it just wasn't available in southern Colorado. We wouldn't stand for that, I don't think, in cardiac care. But we routinely, every day, put up with suboptimal systems, and we're wasting enormous amounts of human capital. So I'm really privileged to be here with you today, and I'm really looking forward to our two presentations, and I'm particularly looking forward to mine, since this will be kind of the first time I've gone through it. And so I expect that you all are going to be very helpful in that regard. Our first speaker today is Dr. Scott Teitelbaum. Scott's a associate professor in the Department of Psychiatry at the University of Florida, and he also has an appointment in the Department of Pediatrics. Scott's specialty is addiction medicine. I'm not going to go in great detail through Scott's resume and his introduction, which you will have at your seat. But as we talked a little bit in preparation for today's meeting, we're talking about many of the themes that I sort of hit in the introduction around the importance of early identification. Pediatrics is really, in some sense, where it's at in terms of the future health of the nations, in terms of a medical care delivery system. And Scott's particular focus, I think, is on addiction. So he's going to talk to us about that. And Scott, do you want to come up? Dr. Teitelbaum? And now we're going to see if Kendra... So I know how to do it. I just need to make the mouse work properly. And the nice thing about this is everyone can see what you're doing, right? So there is no... Don't you love when that happens? I know. Okay, so this is forward and backward, and that's a pointer if you want it.
Forward, backward, okay.
Thank you.
Well, glad to be here. So it's both an honor and a privilege to be here. I'm technologically challenged, so I needed all the help I can get. And I should give special thanks to Kendra, wherever she is out there. The other night while working on my talk, I went to bed and I got up. The talk was gone off my computer, so I was in a little panic yesterday and had to redo the slides and then send them, and I kept redoing them, and I probably sent Kendra 3 or 4 sets, the last being, I think, at 9 or 10 o'clock last night. So she's probably wondering about who this guy is coming to speak. But my goal today, I want to do a little bit of a review about some of the recent developments in addiction medicine, a little bit about what we're doing at the University of Florida, and then move on, talk about some of the fundamental science of addiction, some of the things that we've learned recently, talk a little bit about 2 hot items, which would be marijuana and prescription drug problems, a little bit about teaching and educating our healthcare providers, and a little bit about recovery and treatment. So I was born and raised in New York. I talk fast, and I have 85 slides, so here I go. Well, the first thing is that I don't need to convince the people in this room. I guess there are people in this town that need to be convinced that this is a problem that needs some attention and some money. And, I was looking at Dr. Gold. Many of you know Dr. Gold. I'm not Dr. Gold. That's the one rule that in our Department of Psychiatry at the University of Florida that is paramount, that he's Dr. Gold and you're not. So I'm not. But he gave me some of these slides. And so, I looked at this slide, and, one of the things that stands out, and I like this sentence, is, there is no health without mental health. And I think that, like I said, I'm preaching to the choir in here, but I think there's some other people that need to hear that message. And this is, as the last sentence says, is often ignored and unfunded. And I guess as we speak here today, this is an issue that we're facing. Florida, when you look at drug abuse and drug addiction, we've gotten a lot of attention for some of the wrong things, specifically overdoses and the pill mills. And so when you look at this map, Florida stands out among the states with a greater number of problems. Cost, when you look at the costs, and it was interesting hearing people talk about the bang for the buck. I mean, people try to articulate an argument that the cost is not that high and that treatment isn't worth it, but this problem costs our country and certainly our state tons of money in many ways that people don't realize. And I think that that's an issue that's often missed. We look at overdoses. This is the national toll. Once again, Florida is up there. And if you look at, it's the opioid issue that has led the parade here, and it's not heroin, it's prescription drugs, and that's one of the things we're going to talk about. And Whitney Houston's death has brought more attention to this once again. But there's many people that have overdosed and died in this state and many others that don't quite have her voice and don't get that amount of attention. So this is not just a celebrity issue. Briefly, I'll breeze through some of the University College of Medicine slides. First of all, I know this is Tallahassee. John Harden did wear his gator tie. Rick Wagner did not. Can you write that down, please? And I have actually Florida. My wife told me this morning, and like a good husband, I listened to her, that she said, you're going to Tallahassee, you should wear something red. I didn't realize I was wearing Seminole colors, but if the truth be known, I'm actually a Jewish guy that grew up in New York that roots for Notre Dame, and that'll probably get me out of here fast. Well, our division of addiction medicine, we're quite proud in the three areas: research, our clinical work, and our teaching. And one of the neat things at UF is, and this is a credit to Dr. Gold, is that we're not a red-haired stepsister. We have a division of addiction medicine, and I wouldn't be surprised one day if we don't have the first department of addiction medicine in the country. And it's from research. We're proud of our teaching. We're going to talk a little bit about that. Our medical school is might be the only, but one of few that we have a mandatory 2-week addiction medicine rotation. We have a world-class treatment center. I'll talk a little bit about that. We get sent to us people from certainly around the country. We get a lot of physicians sent from different states to evaluate and treat. And Dr. Gold loves his global talk. I mean, Beijing, India. I'm not sure exactly what we're doing in Beijing and India, but I know we have a collaboration. I stay, I'm a trench guy. I stay in Gainesville and see the patients, but. Perhaps someday. This is Dr. Gold. This is the neat thing about this slide. He gave me this slide, but it's a neat slide because he was actually honored for being a distinguished alumni professor. And once again, it is. He said an influence that our university. When I fill in as chairman, I fill in for him, and I go into the room as a vice chairman, and I sit. I was looking around the room, and last time I was in a room of about 23 or 24 people, and I could count 8 people in that room that I had treated either one of their faculty members, one of the people in their department, or somebody in their family. So this illness does not discriminate, no matter how famous you are, no matter what you do for a living, no matter how smart you are. It just doesn't care. The discovery to recovery. I did not. This slide is an example of 2 things. We're very proud at UF of bench to bedside. We do a lot of research and we do treatment, real live treatment, and we're proud of that. It's also a good example, this slide, of what airbrushing can do to make somebody look younger. This is a slide of all the different places. UF, once again, Dr. Gold, we have, we outreach many places, but it is, in as much as there might be, it seems like there's some grandiosity here, we have extended our outreach in terms of providing good, solid treatment, and for the sicker folks that we need to treat, bringing them on into Gainesville. This is just some of our faculty, and you know, some of the people you might know. Some of them we've recruited many more people. Martha Brown from USF, we recruited her to add to our division. Kevin Weiler, an eating disorder expert from out west. So we have really built the division that can touch all aspects of addiction and be part of the Department of Psychiatry, because you can't separate, as many of you know, with the comorbidity. If you're going to treat substance abuse and drug addiction, you better be well equipped and well versed in treating comorbidity. And once again, the research faculty, and you never know, one of the neat things about the research folks, and this is the nature of research, sometimes you're surprised at some findings how they relate to what you do clinically. Sometimes I'm a clinician at heart, that's what I love, and sometimes I sit there and I'm thinking, oh my God, kind of more research, and then I realize, and you sit back and you realize that all of a sudden, when you least expect it, there's a finding that comes up that really touches what you do clinically. I'm not an eating disorder guy, but eating disorders don't get a lot of attention. We brought Kevin Weiler in from Arizona. I think it was it Remuda Ranch, the eating disorder program, Remuda Ranch in Arizona. And the interesting thing about the eating disorders is that they share in common a lot of the neurobiology. So we're starting to learn a lot of the science with some of the eating disorders does kind of relate and is related to some of the addiction research, especially when it comes to brain reward and obesity and overeating. Some of the, this year's, when we look at progress in the basic addiction science over the last year, some of these things you've heard, but some of them are new. I mean, the first, that drugs change the brain over time. We know that. We've known that for a little bit of time, but now we have neuroimaging, and I'm going to review some of that to support that. Of course, the only 100% treatment is prevention. But when you look at, as a pediatrician, when I was trained in prevention, we always talked about primary, secondary, and tertiary. Primary being stopping, any of the disease at all, initiation. Secondary, identifying high-risk people and intervening. And tertiary, which is treatment at some level. Unfortunately, a lot of the people that want to talk about prevention do it conveniently so that they don't have to fund treatment. But treatment is prevention. Treatment is prevention of the progression of the illness, and people want to ignore that. We're going to talk a little bit about early exposure in pediatrics. One of the things we know that regardless of your genetic loading, if you start using before 15, you're at a much higher incidence of developing a drug or alcohol addiction regardless of your genetic loading, which goes to the next bullet that genetic predisposition. It's not destiny, but it's interaction between the genes and the environment. And some of the science now is kind of showing us that some drug use and some of the effects on the brain, really what they do is they change genetic expression. This is a Neurovolkov slide, and one of the themes that unfortunately I keep hearing from various, sometimes politicians, sometimes other physicians, is that drug addiction is not a disease but a matter of will. This theme pops up periodically. And addiction medicine, actually, it's fascinating in the United States. It's not new. It was around, there was a booming in the field in the 1800s. We didn't have the basic science to support it back then, but there was a field. It was emerging. And what happened was the illness became criminalized again. So it was prohibition. Before Prohibition, it was the Food and Drug Act in 1906, and there was a time from 1910 to 1920, many physicians went to jail for treating opiate dependence. So the field, which was, there was a degree of charlatans in the field, sometimes with some of the magic formulas used to treat addiction, the Keeley gold formula, which nobody knew what was in it. Many of the magic potents had a were magic potents because they had a combination of opioids, alcohol, and cocaine. But suffice it to say that the field went away because of the criminalization of the illness, and that's some of the fear that I have today. But this slide addresses, when you look at somebody with a diseased heart, in the heart muscle, you have this continued injury of the heart muscle long after the event of the heart attack. And when you look at somebody with a cocaine addiction and you look at metabolic activity in the brain, once again, the injury persists well after the drug is gone, just like the injury of a diseased heart will persist long after. And people struggle with this. And I think one of the great things about neuroimaging is that it has given, it's given some hard scientific evidence to the disease. And I don't use disease concept anymore because it's not a concept. There's plenty of science, there's plenty of biology, there's plenty of neurobiology, there's plenty of genetics. So I always get upset when I'm watching late night TV and I see CNBC and I see Chris Prentice from Passages in California, and for a mere $75,000 to $100,000 a month, you can enjoy your massage, you get treatment there, or you could buy his book for $24.95 on the addiction and alcoholism cure. And it's always interesting because he says we don't believe in the disease concept, but his book is called The Cure. And it just, it's no longer a concept. So I was at a talk once where the guy speaking asked for a show of hands of who believed in the disease concept, and when a bunch of people raised their hand, he said, well, you're all doing a disservice to the field because it is no longer a concept. There's there's plenty of evidence. And and we'll talk about this later in terms of treatment, but when you look at the other illnesses that are most similar, you look at hypertension, asthma, and diabetes. Think about it. They all have a genetic predisposition. They all have a clear pathophysiology, but they all have a behavioral component. So somebody with hypertension and a diseased heart that eats Kentucky Fried Chicken and pizza on alternate nights, smokes cigarettes, and is 100 pounds overweight, that has a heart attack and goes into the emergency room, and his doc says, well, they treat the heart attack, and then they say you need to lose some weight, you need to stop smoking and get some exercise. When he comes back a year later with another heart attack, they don't tell him, hey, get out of the emergency room. You've used up your money for this year's treatment of your heart condition. We'll see you. But we do that with addiction. So science has progressed, and this is a slide addressing the decreased dopaminergic activity. I want to make it clear. I was watching some time ago an interview on Charlie Rose. I don't know if anybody's ever watched Charlie Rose, Bloomberg TV. He was interviewing Dr. Watson, who won the Nobel Prize for basically coming up with the DNA double helix. Pretty smart guy, and he's still alive, and he's doing research in I think it's breast cancer, and he's in his 80s, and they were talking about the science and his personal life, and Dr. Watson shared that he had a son with schizophrenia. And Charlie Rose said, well, gee, in today's world, what a better time to have, it's the best time if you can have somebody with a problem. We know so much more about brain biology and neurobiology, and our treatments are so wonderful. And you can see this Nobel Prize winning man, he kind of chuckled and he laughed and he said, well, we know a lot more than we did, but we certainly are far from knowing what we need to know. So, in terms of brain neurobiology, we probably, and people with much more expertise than I am but probably know about 20 or so neurotransmitters. There's probably a couple hundred. We have a lot more to learn. But what we have learned, for example, when you look at this slide, this is a slide of a part of the brain, the midbrain, looking at an area of the brain, the amygdala, which is very important in emotional content of memory. And, people always say, well, what's emotional content of memory? I think when I go back, to where I grew up, and I go back to Staten Island, and I drive by PS 45, where I went to school. If you grew up in New York, you know about PS, public school number. And I go by my old neighborhood, there's a flood of memories that come back, and they just come flooding back. And memories have an emotional content. And when you look at this slide and you look at taking somebody with a cocaine addiction and you show them a video of nature, perhaps the Pacific Ocean or the redwood trees, a person doesn't have much emotional content, and then you could show them a slide of somebody with a razor blade chopping up cocaine, and they light up like a Christmas tree. And this is a significant treatment issue, and it's why when we send our people on passes from Gainesville back to whether it's Tallahassee or Tampa, we make sure that they have a plan, because people, places, and things, their brain will be triggered by certain, perhaps, smells, by people, by events. And now we've known that clinically for a long time, and now we can have some neurobiology and functional brain imaging to look at, oxygen utilization, glucose metabolism, blood flow, to see some of these changes. Just some of the things that we're looking at UF, and I'm not going to go through all of them, but there's a lot of research done in this field, and as much as I said, as much as I love my clinical work, and that's what my joy is, that you need continued research in the field to support, because in today's world, if you don't have the evidence, you're not going to get funding, and you're not going to get paid. And these are just some of the developments that we're looking at. Okay, and interesting, this is just another one, methamphetamine. When you look at methamphetamine brain imagery, injury, very similar to traumatic brain injury, like from trauma. And that, methamphetamine, and anybody that's ever treated a methamphetamine addiction, always one of the things that stands out is the duration and persistence of some of the psychiatric abnormality, some of the psychosis and some of the irritability. Sometimes the injury, the psychiatric symptoms persist so long after the methamphetamine use has stopped. And this represents a significant brain injury that can last some time. And so that would impact how one treats them, because beyond long rehabilitation, you might look at using some of the neuroprotective agents similar to those that you use in trauma. Once again, this is just some of the international stuff. You never want to forget in all these talks about the good old tobacco and alcohol, and smoking. Smoking targets the brain, and when you look at smoking, it is the fastest way to the brain. Smoking, as a previous slide said, smoking is IV without the needle. And when you look at, for what it's worth, when you look at smoking crack versus injecting cocaine, probably a little bit quicker to the brain smoking than putting a needle in your arm. 8 versus 10 seconds, not a little bit difference. And when you look at this slide, route of administration is a critical issue in addiction liability. A best example of this slide would be cocaine. Comes from, the cocoa plant, Peru and Bolivia, and there's not a lot of people in treatment for chewing coca leaves. Why do they chew coca leaves? Because it gives them energy. They could eat less, they could work better. But how many people do you see in treatment for chewing coca leaves? Not a lot. Just like how many people are in treatment for latte addiction? Not a lot. It's reinforcing a little energy, gives you a little buzz, perhaps, but you don't see a lot of people in treatment. All of a sudden, you take the cocaine and you make cocaine hydrochloride, and you could snort it, a little bit more addictive, and then you have crack, and you could get the drug to the brain in 8 seconds, and you have a national epidemic. And actually, Dr. Gold, that's where he became somewhat famous, and it's fascinating. We don't learn well from history. When you look at historically, if you read the American Psychiatric Association's comments on cocaine in the 70s and even in the early 80s, if you go back, look it up. Cocaine was viewed as a recreational drug with a very low addiction liability. We had a ton of people on Wall Street, a ton of entertainers. And Dr. Gold had the long-going debate with a guy named Dr. Lester Greenspan from Harvard. And actually, Gold was somewhat laughed at back then for talking about cocaine having a high addiction liability. And then look what happens. He not only wrote his little book, became famous and a little wealthier, but, look at, was he right? Yes, he was. But the fascinating thing about it, it's crazy. We don't learn from history, whether it's war or the stock market or drugs, because it's not the first cocaine epidemic. There was a cocaine problem in the United States in 1910 to 1920. There were problems when Freud looked at cocaine in Europe, and he treated people. He recognized the drug had addiction potential after his initial writings. So when you look at historically with drug addiction, we repeat it. A drug comes around, it's a panacea. It's considered, drugs of abuse are always considered safe until proven otherwise, whereas other drugs have to go through FDA, trials to prove that they're, efficacious and safe. But drugs of abuse always have a grace period. So, this slide addresses rapidity of the brain and smoking. If you learn how to smoke, you learn how to deliver drugs to a brain. That's a critical issue for adolescents. Drug addiction is not drug withdrawal. If you take somebody with cancer and you treat them with opiates for their pain because they have bone metastases, after a period of time, if you stop the opiates, they're going to have withdrawal from the opiates. They're going to be diaphoretic. They're going to look like they have the flu. They're going to be sweating. They're going to be uncomfortable, just like opiate withdrawal, diarrhea, miserable, craving the drug. That drug withdrawal doesn't define addiction. Drug addiction is a pathologic attachment to the drug. Drug withdrawal is not. So the idea that one has to have tolerance and withdrawal to have drug addiction is just not true. Drug withdrawal and tolerance are neither necessary nor sufficient to make the diagnosis. Drug addiction is defined by three paramount behaviors: a preoccupation with using, continued use despite adverse consequences, and failed attempts to cut down or control the drug. It is not withdrawal. And this is a common misconception even among our physicians. We know today that activation of the reward pathway, that all drugs share this in common, increasing the amount of dopamine available. What's becoming clearer today with the different drugs is they do this by different mechanisms. But all drugs of abuse share this in common. This isn't new. This has been around a while. But what is changing is the knowledge of how they do this. If you notice, the drugs that are missing from this list are hallucinogenics. You can get monkeys, brilliant monkeys. Monkeys are smart. You can get them to do a lot of things to perform, to do more cocaine. They'll forego the cutest opposite sex monkey in the colony. They'll forego a boatload of bananas and to continue to use cocaine. If they have a seizure and an overdose, they will wake up and the first thing to do is do more cocaine. You don't see hallucinogens on here. Monkeys or rats are not interested in tripping and listening to Jerry Garcia for some reason. It's more of a human experience thing. There's many, I talk about some of the biology, but there are other factors that go into the individual's susceptibility to a drug. And you don't want to forget them. I want to make sure that I mention that there's the biology, there's the genetic predisposition, there's the drug itself, okay? There's the route of administration. There's sociocultural issues as well. We're a fast, quick fix, don't want to suffer society. That's just the truth of what it is. And my pediatric experience, when I first trained in pediatrics, my first training was that we were taught in the first couple of years of life, we never used cold and cough formulas. If a child had a cough or a cold, we made sure it wasn't a manifestation of pneumonia, meningitis, something more serious. If the child was really young, we did what we call our septic workup. We cultured blood, spinal fluid, and urine. But if the child had a viral illness, we reassured the parents and we explained that time was necessary. And then my career went on, and all of a sudden I go into CVS pharmacy and you would see Pedicare, infant cold and cough formula, different ages, 1 to 3 months, 3 to 6 months, 6 to 9 months. And, what happened? Our kids got so smart because they went to daycare and they learned to talk early? I don't think so. Or did we have sets of parents that lost? There was no patience. Kids are sick, both parents are working, I need my kid better, and I don't like I want my child's cough and cold better. I want the symptoms to go away. So they started using more decongestants. Well, what's the most common decongestant in use? Pseudoephedrine. Pseudoephedrine is quite a potent stimulator. What can you make from pseudoephedrine? Oh, methamphetamine. So, parents would wonder when they give their kids Sudafed at night. Don't forget, babies are obligate nasal breathers. They make all sorts of noises. I won't do them for you at night. But they sound terrible, but they look okay. And the parents didn't like the way they sounded, so they would give, and surprise, surprise, if you give a baby pseudoephedrine before they go to sleep, you think they sleep better? No. And then it took the Academy of Pediatrics. Now it's come back full circle, and they say, gee, we need to be a little more careful and stay away from the dextromethorphan for coughs and the pseudoephedrine for colds in our younger age. But this is a sociocultural issue, and the same goes for pain and anxiety. And I'm not dissing pain, and I'm not dissing anxiety disorder, but everything that causes pain doesn't need an opiate, and everything that causes anxiety does not need a Xanax. You don't want to ignore psychological and environmental issues. When you look at opioids, it's fascinating. Every time we have a war, the opiate, this isn't our first opioid epidemic. If you go back in history, the hypodermic syringe was invented before the Civil War. Before the Civil War, it's hard to make advancements hard to do surgery. Surgeons were called barbers before they drove Porsches and acted not so nice. Because you couldn't do a lot. You'd use alcohol, you pour it over the wound, and you do what you need to do. Anesthesia and pain management changed that. And if you go back in Google history, you'll find that addiction was called the soldier's disease or the army's disease. Following the Civil Wars, our country endured an epidemic of morphine dependence. People were exposed to morphine for legitimate pain. They had terrible wounds, and then their brains recognized that morphine felt good. It eliminated not only their physical pain, but their psychic pain. Life became soothed, the pain of life, and off they went. So interesting thing about war is when you look at the guys coming back from Iraq today, our veterans, we have an epidemic of oxycodone and hydrocodone dependence for the same reason. You're in the Mideast and you see your buddy blown up. There's a lot of psychological pain. You also have physical pain. You're exposed to opiates, and you quickly find for many people that not only your physical pain is better, but that enduring the emotional pain of war. So my point about is abuse and trauma drastically increase the propensity to develop a drug or alcohol addiction, and certainly environmental factors go along with this. And this is just another slide to look at the interaction between the individual, environment, and it's not a simple thing. While I do stand up here and talk a lot about the neuroscience and the biology, I want to make it clear that that's not all that is around. You talk about the science. This is a slide. Well, what are the drugs of abuse attack? Most of the attack is on much of it is on the prefrontal cortex, and you look at it and you see reduced metabolic activity in cocaine addicts, and then unfortunately the prefrontal cortex is important for, decision making, weighing risk versus reward, assigning emotional valence to stimuli, suppressing impulses, goal-directed behavior. So it's no surprise, when we look at adolescent neurobiology that you don't need science to show this, but what is shown us in the adolescent brain is that the reward pathway develops more rapidly and quicker than the pathway and the prefrontal cortex for judgment, impulsivity, and decision making. Now, you don't need neuroimaging to tell you that if you have adolescents or know them, but it's a critical issue because now with exposure, we're exposing much younger people to drugs that have addiction liability. And basically what you have is a motivational toxicity, and thus the hijacking of the brain, which I think, Bob DuPont, who is America's second drug czar and still quite active in this field, talked about his book in The Selfish Brain years ago as a brain being hijacked. And, that's basically what happens is this drive for reward basically hijacks the decision making, and that is why you see people do what they do. And I want to make it clear, in our treatment center, we never endorse people using their addiction as an excuse for their behavior. Just like I have a 24-year-old daughter that 2 years ago called me from the emergency room in diabetic ketoacidosis. She's a diabetic. She's not responsible for having diabetes, but she is responsible for eating right, exercising, taking her insulin. And when we treat people, we don't use disease as an excuse. They are responsible for their recovery and for their behaviors that they engage in when they're using. Keep in mind, in 1962, only 2% of the population ever used any illicit drug over 12. And now, we're at 50%. And if you look at 15-year-olds, you're at about 15%. So times have changed, and not for the better. And so when we look at adolescents, it's a problem. It's a big problem. And so let's look at some of the issues in the youth. And the first one I want to talk about is marijuana. It just cracks me up. The whole medicalization thing was a tricky little move to get the drug legalized. I mean, we'll talk about that at the end, but here's a Time magazine, Is America Going to Pot? I'm not going to go through all the composition of marijuana, but suffice it to say it's filled, besides having the THC and the other psychoactive components, it's filled with a bunch of things that are not good for you, including carcinogens. When you look at the numbers here for past year marijuana use, and if you see a steady little bit of increase over the past few years in all 8th, 10th, and 12th graders, and this is the University of Michigan monitoring the future study. And look at the numbers; they're not small. Look at 8th grade. Look at 8th grade. You're between 10 and 15%, and by the time you get to 12th grade, you're in 35%. Okay, and when you look at this, is an interesting slide because this is looking at youth and first exposure to any drug. Okay, not uncommon. Marijuana is the drug that you would see. People would expect that, but look at pain relievers are going up. As a matter of fact, since 2005, the numbers are impressive. That there are many kids using for the first time that are getting exposed to either oxycodone or hydrocodone to get high. So this is the first use of a drug, marijuana leading the way, but pain relievers coming in second and gaining. Inhalants are interesting in that they're the only drug that you have a higher use in 8th grade than you do in 12th grade. This is, the idea that you don't treat marijuana as a primary drug of choice is just wrong. In our treatment center, we recently treated a physician from another state being evaluated actually this week. So is that like my time there? Don't worry, I'm moving on. I got you. Okay. Before I get yanked. Okay, we're making it. Okay. This is marijuana. We treated a guy this week, a physician from another state, from North Carolina. Actually, I'm not going to tell you. There's a lot of docs in North Carolina. Say drug of choice, spice, synthetic cannabinoid. Marijuana tells us a lot in terms of. If you look at this slide, this tells you this is a critical issue and the most important issue of perceived risk of a drug is inversely proportional to initiation. In other words, if you look at the years since the 70s, as risk goes up, as the kids think it's more dangerous, they're less likely to initiate. As risk goes down, they're more likely to initiate. This is drug perceived risk is the most critical issue in initiation. Once the brain's exposed, all bets are off. It doesn't matter. Is it a gateway drug? Well, so just some facts to support that. I told you I was a pediatrician. I also trained in child psychiatry. What was my youngest patient? With the family's permission, I took his picture, and he's now clean and sober in daycare, and I think doing well, right? Johnny's in our treatment program? Okay. This is where THC goes in the brain. Notice the area of reward, but notice also the other areas, the hippocampus, all the things that we learn. It's just another example of science kind of helping us identify how a drug works by where it goes in the brain. Marijuana affects, if you look back and you look at that slide, here's some of the area it goes to. But one of the confusing things about marijuana, people thought it didn't have any psychiatric issues. Not so. Not so fast, my friend. In people with a genetic predisposition to certain psychiatric issues, marijuana can cause significant problems. Now, any drug, and this was a good slide. Any drug used too much can cause significant depression. Okay, and we know today, we won't review all the different, but when you look at the different pathways that different neurotransmitters have, there's a relationship between the neurotransmitters. So it's always, chuckling to me when a patient comes in and is abusing drugs and alcohol, but also taking antidepressants, okay? So drugs do change the set point for reward and pleasure and lead to depression. Marijuana is associated with psychosis. let me just briefly say that no, it doesn't cause psychosis. Most people that smoke marijuana don't get psychotic. Most cases of psychosis are not from marijuana. But in the genetically predisposed, marijuana can flip somebody, and I've seen it not once, but many, many times in my career. It's not a case. This isn't the old Reefer Madness movie. There's an element of people that are predisposed that this will be an issue for. And motor vehicle accidents, marijuana is the most common drug that is identified beyond alcohol for crashes, okay? Briefly, I'm not going to spend a lot of time here. I'm just going to say that the medical use of cannabinoids, yeah, there's potential medical uses, but what happened to research looking at marijuana versus other drugs before we just vote on it? We don't vote on other drugs. Why are we voting on marijuana? And by the way, who would ever tell a patient to smoke any medicine? It is the most dumbest, craziest thing to inhale something with carcinogens and smoke when you can't regulate the dosage and the amount, and to tell somebody with like immunosuppressant to smoke a drug. You would deliver it in a different mechanism. So if indeed the cannabinoids are effective for some disorders, which they might very well be, you would not deliver it in smoke, okay? Prescription drugs, this is an issue, increasing primarily opiates, but also sedatives. This generation RX, it's a problem. Look at those numbers. 20% try Ritalin or Adderall without a prescription. Over-the-counter cough medicines. Prescription drug addiction is very real. And if you look at 1 in 4 high school seniors, you'll find that, they've used one of those classes of drugs for non-medical reasons, okay? Here's an old drug, probably wouldn't pass today's FDA standards. Okay, so we have a challenge here, okay? And when we look at our youth, it's a great challenge, and it's not just the illicit drugs, it's prescription drugs that they're getting from their cabinet. This is just another drug, as are the next few slides, to look at adolescents and non-medical use of opioids primarily, but also psychostimulants, tranquilizers, and sedatives. And all these slides, which are in your handout, just speak to the increasing problem of prescription drugs. Opiate prescription have gone through the roof. It's important that people that treat and manage pain have the ability to and the savvy to know what they're doing with respect to addiction. It's hard to treat pain unless you know what you're doing with substance abuse and addiction, and that's critical. And one of the things we do at UF is we make sure that all our pain physicians are clearly trained in identifying and evaluating people with abuse and addiction. This is just more high school for opiate addiction. Treatment for opiates is rising, not so much for heroin, but the other opiates and synthetic. The last couple of things I want to talk about, I'm getting there, don't you worry. Doctors stink in making these diagnoses, okay? Here's who refers people to treatment. Only 3% of people referred to treatment come from physicians. They come from other places. We're lousy, we're not good, and that includes psychiatrists. Psychiatrists are no better. They wouldn't like to hear it. I'm going to tell you, in our town, no better. No better than the internists, no better than the pediatricians. And it's a problem. And one of the things that we are, this is just a slide to look at, that they don't screen well for alcohol problems. And the reasons that they don't screen is, A, they don't know what to do. These are the most common reasons. They don't think there's effective treatment, not really a medical problem, or they have no time. Lousy, lousy, lousy. So one of the things that I'm most proud of at UF is our medical students have a mandatory 2-week rotation in addiction medicine. We don't care if they're going to be an obstetrician, a psychiatrist, or a pediatrician. They'll rotate with us. And I've been there now 15 years, and I can tell you one of my medical students who's not in recovery, Dr. Mirabli, is actually medical director of Vince Carter at Stewart Marchman. So it's made a difference. If you educate them when they're teachable and not when they think they learn everything, they'll be more savvy and more able to identify and get people for the help they need. So it's a mandatory rotation. We're very proud of our leadership there. We are now one of the 3 model programs in the United States for training residents in addiction medicine. I want to finish with just quickly talking about the issue of recovery and treatment. One of the things that people had talked about for years is, why do physicians get treated special? That physician treatment was something that, they just held them longer. They had licenses. But we've learned a lot about treating for physicians. And what we've learned is that that we know that recovery takes time. Science has shown us that brain doesn't heal for a long time. And even though addiction targets the brain, okay, recovery is still a healing of the heart and soul. And it takes time, and it takes time to get to people. So when you look at the recidivism in drug addiction and when you look at the recidivism of other illnesses, it's quite similar, looking at type 1 diabetes, hypertension, and asthma. The numbers are similar. So when we treat people and we treat doctors, Betty Ford, people say, well, why do doctors do better? So they looked at 900 physicians from 16 different states. And what they found, and they looked about, recovery. What is recovery? It's a combination of sobriety, personal health, and improvement in citizenship, okay? Because recovery is not just abstinence. But when you looked at the doctor's studies, you look and you say, well, why do they do so well? Why do the physicians do so well? The doctors would like to tell you it's because they're smarter. It's not the case. Here are the essential ingredients. And this is critical because this impacts how we treat other people. We need to treat, the contingency management is critical, and that is what we've learned in drug courts. That if you hold people, it allows you to hold people for as long as they need to be held, okay, for a period of time, enough to get motivation to change from external, I want my license, to internal, I need to change. If you're treating somebody with hypertension and you don't monitor their blood pressure, you don't know until they've had a heart attack or a stroke. Frequent random drug testing, abstinence standards, linking them to 12-step recovery, focusing on long-term 5-year outcomes, and intervening when they relapse. Those are the critical elements of physician treatment that are very applicable to treating anybody. Contingency management, long continuum of care, following up and testing. You just can't treat somebody and throw them back out there because then when they relapse, you won't know. And these essential ingredients of the physician treatment are now areas that when people look at treating younger people, looking at the same thing, continuum of care, monitoring over a period of time, making sure you have not follow-up care, but a continuum of care. We face a lot of challenges today. And I tell people, John and I always talk about when we're going to hire people, if you're not going to work for us unless you have a passion for what you do. This is a difficult field. There's a lot of challenges. There's a lot more young people using. There's a lot of recidivism. There's a lot of tremendous amount of dual disorders. There's poor education of docs. We have a lot of work to do. But I think that with people out there and the force out there and people continuing to push forward, that we'll continue to make progress. And, like I said, if you're not going to have if you don't have hope and you don't have passion, you should be in another field. Well, I know I talk fast, but I came pretty close, didn't I?
That was perfect.
I really appreciate everybody listening to my fast New York speech. I haven't lost my accent. I thank you, and I wish everybody well.
Yeah, well, that was a terrific talk. Not only was it almost 45 minutes, man, when I saw 85 slides, I thought even a guy from New York can't talk through 85 slides, and did a beautiful job.
I got, intimidated when you start putting up.
I tell you, we had to find a magic marker and everything. Lots of important points. The gene-environment interaction, we're going to talk a little bit more about that, about vulnerability and then exposure. The developmental perspective, it takes time for these things to develop, and at some point, the brain literally changes. I think that the ending with this, I love that definition of recovery, by the way, because that's one thing our field continues to struggle with, is trying to come up with a definition of recovery that works both for both people who have mental health conditions and people who have addiction disorders, and I really like that one. And I think ending with the physician example is an excellent one around contingency management and what it takes to recover, the kind of support that people need. So it was a terrific talk. If we have a few questions, we're going to have a sort of a question and answer section later. But if there are any pressing questions for Dr. Teitelbaum right now?
Yes.
Any research about use of psychedelics in treatment?
Rarely, people, you don't usually see psychedelics as the primary drug of choice. You see them used with other substances. So, you're talking about the use of it? Well, yeah. Well, The research has not been that promising. I know that Deborah Mash and Jeff Kamlet, they did that. I mean, the problem is you have to do, it's kind of like rapid detox. You have to weigh, risk benefit. And the Ibogaine has had some significant both neuro and cardiac toxicity. And the people, I've treated a fair amount of people that had their spiritual awakening while taking Ibogaine, while in St. Kitts. Let's see, do I want to go to Mississippi and talk about my feelings, or a trip on St. Kitts Island? The problem is there's no magic cure. And when you're looking, we can look for drugs that help us. And I'm open to that. But at the end of the day, with all the science, recovery still, you've got there's time. There's time for brain healing, and there's work on the emotional issues, the heart and the soul. And the Ibogaine, that's why you don't see any literature in ACM about Ibogaine. It has not been that successful. It's anecdotal. Yes.
What's your 30-second elevator speech to somebody who believes addiction is a bootstrap issue?
Well, my quick answer was don't let the facts get in the way of your opinion. Most of the people that have these passionate arguments about willpower, in my experience, you usually find somebody in their life has injured them. A mother, a father, a sister, a brother. It's just not... my answer, and people don't like it, I'm a New York guy, so I'll say, well, that's like telling me the Holocaust didn't happen. I think there's plenty of science, there's plenty of evidence, and there's usually other motives there. Yes?
I think you mentioned earlier something about spice, and I've seen it in my community, and I've seen a lot online, working people that weren't drug users that started using this over-the-counter or whatever, and it's addictive.
It's very addictive. It's a problem. It's a synthetic cannabinoid. The cannabinoid receptor. Some of the spice and the K2, it has all different names. They tweak the molecule, some being much more potent than THC itself. And I can tell you the physician that we recently treated, overwhelming devastation of his family, unavailable to his children, couldn't stop smoking.
How did he get for insurance purposes?
Well, that's a good question. I gave him a diagnosis. I know the DSM-4 doesn't have this. I gave him, because he had a history of cannabinoid dependence. So we gave him cannabinoid and synthetic cannabinoid dependence. I mean, yeah. Yeah, but we've had other people. Here's the problem. A lot of the youth have figured out the testing lags, so they'll be in treatment and they'll smoke spice because they know you can't pick it up. You can do some, you could do some testing for spice and K2, but they tweak the molecule and then you won't get a positive. So it's a way for people in drug courts and in treatment to continue to use and not be detected. It's a problem. Yes, sir. It's the Ibogaine guy.
Yeah, I was also going to ask you, or thank you for mentioning 12 steps in your recovery model, but also mention that I've seen a lot of value in faith-based organization being part of recovery.
Well, I want to make, that's a good point. Treatment, and we talk about this all the time, treatment should not be a this or that. It should be a this plus that. So one doesn't exclude the other. So my message to my patients is you keep going to church or synagogue and go to meetings. And if you need Lexapro, you take your Lexapro. And if you need CBT, you need CBT for your anxiety. I have a great disdain for these conversations of this or that. Treatment should be a this plus that. So there's nothing incompatible with the steps. There's, and faith. They don't have to be a this or that. It should be a this plus that.
Great. I think that's a great note to end on.
Thank you.
And next we're going to hear from Dr. Charles Nemiroff. Dr. Nemiroff has a very distinguished career working in psychoneurology, understanding the pathophysiology, the development of depression and other mental disorders. He's published over 500 papers, 5 times as many as me, in the area. A very distinguished career at Emory University and is currently the chair of psychiatry at that other Florida university, one of the other Florida universities, University of Miami, and he was bemoaning the fact that he didn't bring a lot of his hurricane stuff here, not knowing that Scott was going to give us a 15-minute commercial about UF. Charles.
I was moaning, and I'm from New York also, but I've lived in the South for so long, I don't talk as fast as Scott does. So I'm sorry about that. I have the best job in the world. I'm at a great university, and I get to hear people's life stories every day in my clinical work, and many of you do too. And it's a privilege to hear people's life stories. And their stories are humbling to me, and I'm sure they are to you. People go through a lot in their lives, and some of them are vulnerable for psychiatric disorders, whether it's schizophrenia or depression or bipolar disorder or substance abuse. And so, we are truly, truly doing God's work, and it's humbling. Some of us are humbled by our patients, and some of us get humbled by our spouses. So I thought I'd tell you a brief anecdote about my wife. I was fortunate to be elected to the Institute of Medicine of the National Academy of Sciences. That's really quite a high honor. There are only 55 psychiatrists and neurologists in that organization. And I was in the hotel room in Washington putting my tuxedo on, and I said, honey, in your wildest dreams, did you ever think that I was going to be elected to the Institute of Medicine? She said, well, you're not actually in my wildest dreams. I'm going to continue with several anecdotes while we try to find my slides.
I could do that for you.
Okay.
That's terrific. But I would like another one like that. That was a great one.
So I'm in my third year as chair of the Department of Psychiatry at the University of Miami. We are the best funded Department of Psychiatry in the state of Florida from the National Institute of Health. We've climbed to number 29 in the nation out of 175 medical school departments of psychiatry. And we're the fourth best funded department at the University of Miami. And our focus is largely in the area of schizophrenia and mood disorders. Thank you. So I'm wearing a bracelet here which has the colors, which says, fight for mental health. And, so I'm going to talk to you. I'm going to try to keep this spirited and lively and educate you while I talk to you about sort of a depressing topic, which is depression. But I'm going to try to do my best, and I know there are folks with varying backgrounds here, so you'll bear with me, but I'm going to have many of the points that Scott made, and I was particularly taken by the question about what do you do about the legislator who says to you, just pull yourselves up by your bootstraps. And having lived in Georgia for a long time, I can assure you I dealt with that on a yearly basis. And in my mind, the most compelling evidence actually is the genetic evidence. And it can be relatively easily explained to a lay person, even a politician. Okay? But generally what I say is, if you take twins, a group of identical twins, and a group of non-identical twins. The identical twins have the same genetics. And you look if one of those twins has manic depressive illness or cocaine abuse or alcoholism or depression, the chance of the other twin having it for the identical twins is huge, even if they're separated at birth and that they have different environments. Whereas the non-identical twins with different genetics, it's not as closely linked. And so even they can understand that if you have the same genetics, you have the same vulnerabilities for these brain disorders. And that seems to have worked pretty well. It didn't particularly translate into increased funding, but at least got them to understand and treat. Everybody knows somebody that has a psychiatric illness. Whether it's depression or substance abuse or schizophrenia, even the folks that are making these tough decisions about the budget. So let me talk to you about depression. If you just think about the worst day of your life, the very worst day of your life, and think about feeling that way every day and not knowing why, that's what depression's about. And Shakespeare did a phenomenal job in this quote talking about it. And he said, canst thou not minister to a mind diseased pluck from the memory a rooted sorrow, raise out the written troubles of the brain. So Shakespeare knew this was a brain disease. And with some sweet, oblivious antidote, a good treatment, cleanse the stuffed bosom of that perilous stuff which weighs upon the heart. That's a phenomenal description of what, unfortunately, 21% of American women and 13% of American men will suffer in their lifetimes. This is a very, very common disorder. And lots of famous people have suffered from it, from Abraham Lincoln to William Churchill. And this is a fabulous quote because it speaks to the issue of people thinking that this is sort of like a little bit of sadness. So William Manchester, in his description of Churchill, said all his life he suffered spells of depression, sinking into the brooding depths of melancholia and emotional states which, though little understood, resembles the passing sadness of the normal man as a malignancy resembles a canker sore. And I don't know of a better, William Styron was one of my patients. He wrote Darkness Visible. I took care of him for many years. If you haven't read it, it's a nice little volume, miserable read because it's so painful, but it's about what depression is like. No one volunteers to have this. Trust me. So let's talk about what it is. It's a syndrome. It's sort of unfortunate we use the word depression because we confuse it with other things. People say things like, I'm depressed because the Marlins haven't had a winning season, and so, well, you're not depressed. You're a little irked about it, okay? I was a little irked about the Miami Hurricanes football season, okay? But I wasn't depressed. So what depressed is like is feeling blue, hopeless, down in the dumps every day for at least 2 weeks or more. And for most people, it's a lot longer than that. And then you have to have one of these, 5 of these other symptoms. And there are some that you worry about more than others, but the pathognomonic cardinal feature of depression is an inability to experience pleasure. Now just think about that. All of us sitting in this room, hopefully, like to do some things. We like to hang out with our dogs. We like to go to sporting events. We like to go fishing. I was fly fishing on the Texas coast this past weekend, didn't catch a damn thing. The weather was terrible. But I had a good time. But think about not being able to experience pleasure. Think about what it would be like if you won the lottery and it wouldn't feel good. It wouldn't change how you feel. And that every minute's an hour because you're suffering from what we call psychic pain. Just miserable that you can't stand being with your grandchildren. You get no pleasure out of that. You don't like to see your kids' soccer game. It's an awful, awful state. And it's associated with a loss of appetite and weight loss, although about 20% of folks have an increase in appetite and weight gain. And the worst part of this disease, apart from the risk for suicide, which we'll talk about in a minute, is the sleep disturbance. It's bad enough you feel bad, but if you can't sleep and you have trouble falling asleep, you wake up during the night, and then the worst, you wake up at 4 in the morning and can't go back to sleep. That's called early morning awakening. There's no other medical or psychiatric syndrome that mirrors those symptoms of a sleep disturbance. And you have trouble concentrating. And the worst part of it, if you look at this sign here, is that you feel that you have, it's your fault, that you have overwhelming guilt and self-reproach. I'm a loser, it's my fault. And sometimes it takes on psychotic proportions. God's punishing me. I'm such a bad person that God has decided to punish me. Well, that's not good. So, how common is this? It's really common. I told you 21% of women in the United States will suffer an episode in their lifetime. These are point prevalence rates. So, in the community and primary care settings, in the clinics, and most physicians are really not good at diagnosing this. Part of it is because they're afraid to ask. Good family doctors and internists say to me, look, Charlie, if I ask about either suicide or depression, it's going to take me 35 to 45 minutes, and I've only got 18 minutes to see this patient. So it's better not to ask. Oh, that makes a lot of sense. You can see that this is a real issue for folks that have medical illness. So how much education do psychiatrists get in diagnosing depression? A ton. How much time in medical school and in residency is devoted to psychiatry for cardiologists, orthopedics, endocrinologists? Almost none. Almost none. You have one rotation in medical school, and in family medicine you get either 1 or 2 weeks. In internal medicine you don't get any. 2/3 of depressed patients are actually treated by non-psychiatrists. So we have a real problem in terms of access to care. And then there are certain settings in which depression occurs in very high rates, namely in nursing homes. We have 1 or 2 of those in this state, if you haven't noticed, and in medical patients. So we have, at our cancer center at Sylvester, we have 2 full-time psychiatrists, 2 full-time psychologists. Every patient is assigned a social worker from day 1 that takes them through their entire treatment. And a lot of them get depressed. And you know what? If you treat them, they do really well. So why is this important? Scott made an impassioned case for the treatment of substance abuse being cost-effective, and it's absolutely the case for depression. This is a collaboration between the World Bank, the World Health Organization, and the Harvard School of Public Health. And they prepared a report called The Global Burden of Disease. And what do you see here is that major depression by the year 2020 will account for more disability than any other disorder except for heart disease. Heart disease. And I'm going to try to convince you that the disproportionate amount of funding away from psychiatric disorders is economically a bad idea, as well as in terms of human suffering. So less than half of patients with depression are actually diagnosed. So they suffer. They suffer in silence. And their families are affected. There are certain forms of depression that are particularly deadly to think about. Postpartum depression. There is no more critical period in life than the moment a woman gives birth to her child and needs to bond with that child in that first month of life. And if you are horribly depressed as a mom, you can't form that attachment with that child. And that child's going to be affected for a long time, probably lifelong, and it's not a positive effect. And postpartum depression is not diagnosed by gynecologists and obstetricians. It's not recognized, and it has a high rate of suicide associated with it, and unfortunately, infanticide. Then of those folks, the half of the patients who are actually diagnosed, only about half of them actually get treated. And the reason that is there's a stigma about getting treated. I don't have to tell you all about stigma. I had a patient, I get a lot of high-end referrals. I had a patient say to me the other day, can you do a house call? I said, a house call? I don't do house calls. Well, what if somebody sees me come to your office? I mean, I'm in the public eye. If somebody sees me, it's like, I don't know, you want to come up the freight elevator? I mean, I'm not doing a house call. So, and then Scott alluded to this, and I'm going to spend a lot of time talking about this, is the issue of matching the best treatment to an individual patient, because that's where the future of psychiatry is, and I want to talk to you a little bit about the future. So just to define a little bit about depression, what you're looking at here is the spectrum of mood disorders. I don't have enough time to talk to you about all of them, but what I wanted to point out is that there's the normal mood swing all the way on the right of the slide. We all have ups and downs related to our relationships and our jobs and all sorts of nuances in our life. Those are normal mood swings. But you can see when you get to unipolar depression that folks vary from being sort of euthymic in the mid-range of mood to plunge down into severe depression. What I won't talk to you about today, but I'll answer questions about, is bipolar disorder or manic depressive illness, where patients go from being pathologically high, euphoric, grandiose, and often psychotically so, to being terribly, terribly depressed. We have really good treatments for this. Now, we have an epidemic of suicide in the United States and in the world, and I feel compelled to take a few minutes to talk to you about this. So we were doing pretty well, and I say we because I'm on the board of directors of the American Foundation for Suicide Prevention. I was the president of that national organization. I'm now the president of the Southeast chapter. Look how well we were doing in reducing suicide rates. We got it out of the top 10 causes of death in the United States in 1999 and 2000. It was below 33,000. It was about 31,000 total suicides in the United States that we know about. Okay? Now look what's happened. Why has this increased, and why is it this year going to be number 9? Number 9. We've managed to get above 40,000 deaths from suicide in the United States. How did that happen? Well, what is suicide about? It's largely about untreated or undertreated depression. Although folks with other disorders commit suicide, the vast majority of suicides are people who are hopeless and helpless and finally give up and commit suicide. What happened? Well, number one, we had more suicides in the military than we did deaths from combat this year. I want you to, did you hear what I said? Think about that. More veterans and active military died from suicide than they did in Iraq or Afghanistan. Okay? That is a phenomenal number. The economic downturn in which people lost their homes, lost their jobs, etc. I had a patient, an 81-year-old attorney, say to me the other day, you know, it's rational for me to commit suicide and leave money to my family. I'm smart enough to do this without anybody knowing, because, you know, my life insurance policy doesn't pay for suicide, but I'll just drive my car into a tree at 100 miles an hour. That's not going to be considered a suicide. Needless to say, I intervened. But the fact of the matter is, we have an epidemic here, and it's worldwide. 1 million people killed themselves last year in the world. 1 million people. 250,000 women killed themselves in China last year. Okay, all because of untreated depression. 90% of it is untreated depression. A lot of comorbid substance abuse. The vast majority of people who commit suicide are drinking when they do it. It lowers your inhibitions in a terrible way. Depression doesn't travel by itself. It's got a lot of colleagues going with it, other psychiatric disorders. And this slide shows you that patients with depression suffer from other disorders, largely anxiety disorders, panic disorder, post-traumatic stress disorder, a huge problem with the returning veterans. You know, we have at the University of Miami 280 inpatient psychiatric beds. 280. It's part of what I negotiated when I moved to Miami with the dean, was the fact that we had to have a large psychiatric service. When I left Emory, we had 18 psychiatric beds at Emory Hospital, because guess what? I'll tell you a secret. Psychiatry doesn't make money. I know you're stunned by that. So I have 150 beds at Jackson Memorial Hospital, have 104 beds at the University of Miami Hospital, and 30 at the VA. And you know what? They're full almost all the time, because there is such a need. Unfortunately, of course, our length of stay is about 5 or 6 days, but at least we can get people out of trouble. So this is the way we think about depression. The good news is it's a treatable disease, okay? It's a treatable illness. It has evidence-based pharmacotherapies, and psychotherapies. Evidence-based. Our data on the efficacy of antidepressant psychotherapy is as good as antibiotics and infectious disease. Okay, make no mistake about it. We don't need to take second fiddle to anybody. Our treatments work. And all of you who take care of patients, you know that. So we see people, and as you know, they come in and they're symptomatic in the acute phase, and we treat them, and what we've learned is they have to be treated to complete remission. They have to be treated. You have to treat depression like you do cancer, okay? If, God forbid, you had cancer and you went to an oncologist, and the oncologist said to you, you know what, I'm going for about a 20% reduction in your tumor load. You'd say, what? You want to stamp it out. We have to stamp out depression. And what we've learned is that all the bad things about depression persist if you're not in complete remission. So what are the bad things about depression? We already talked about risk of suicide and substance abuse. How about the fact that depressed patients are 4 times more likely to have a heart attack than non-depressed patients? Because depression is a disease. And it's a disease that's characterized by inflammation. So women with depression, it eats their bones away. They got decreased bone density. They're more likely to have hip fractures and spine fractures. Depression is one of the worst things you could have if you have breast cancer, because it increases the risk of metastatic breast cancer. A new meta-analysis has shown that if you have metastatic breast cancer and you're depressed, you die substantially faster than if you don't have depression. So depression is a brain disease that changes your body and causes really bad things like stroke, heart attack, and risk for cancer. You also do things when you're depressed behaviorally that you shouldn't do. You don't take the medicines you're supposed to. You engage in risky behaviors, so you're more likely to take part in either substance abuse or risky sexual behaviors. You know, as an aside, you know that we have the highest rate of sexually transmitted diseases in the elderly in the United States, in this state. Well, how does that happen? Well, I think you know how it happens. Because elderly folks come down, all these Yankees come down from New York, you know, and they retire. And their wives, God bless them, they make friends, and they're like playing cards and going to book clubs and having a great time. But the men, you know, as my wife would say, testosterone is a poison, okay? So the men, of course, it's harder for them to make friends, and their golf game isn't what it used to be, and, you know, so what did they get in trouble? And they end up with sexually transmitted diseases. I diagnosed a 78-year-old man with HIV infection last year, okay? Because 78-year-old men don't know about condoms, okay? So depression, did you say they don't know about much? Well, unfortunately, that's part of the story. That's part of the story. So we ought to do a combo pack? Oh, okay. I'm not going there. I'm not going there. So, depression is a treatable illness, okay? Let me, I promised I'd stay on time, and by God, I'm going to stay on time. So here's the future of all of psychiatry and all of medicine right here. The dean at the University of Miami, Pascal Goldschmidt, is a cardiologist. He and I have been working on this depression heart disease link together, and we put this slide together. He told me privately that if he was going to go to medical school again, he'd go into psychiatry. So, you know, God bless him. Where medicine has been for many years is all the way on the right side of the slide. We see people when they're sick. They come in, they have cancer, they have congestive heart failure, they have terrible depression. Where the future of medicine is right here, okay? So with the advent of genetics, I'll show you some data. With the advent of genetics, we're going to be able to determine who's at risk to get these diseases. Wouldn't it be a great thing to be able to say to a parent, you know, your child is a little vulnerable, and you ought to sort of be careful with them in terms of stress, because they're more likely to get depression or an anxiety disorder or post-traumatic stress disorder than someone else. Or you might say, your child has all the resilience genes and they'd be a great Green Beret, or fly the plane, I'm going to fly back to Miami tonight, right? So this is the future. The second area that this is really going to solve for us is matching individual patients with treatment. So experienced physicians, psychiatrists, always tell you that when a patient comes in their office and that patient is morbidly depressed, that they know what the best treatment is. They don't know. They don't know. There's no evidence that they know. We're working on it. We have a lot of NIH grants to look at this, but the fact is they don't know. When I see a patient who's depressed, should they get cognitive behavior therapy? We know it works. Should they get an antidepressant? We know it works. Should they get the combination? I don't know. So what I do is I always try to get them to do psychotherapy and an antidepressant together. But which antidepressant? We've got 15 or 20 antidepressants to choose from. And if I pick a single one and give it to a patient, the chance of them getting into remission is about 35%. That's it. That means 2/3 of the folks aren't going to get better, at least immediately. And that period of time, those 8 weeks, can be really important, and the patient's suffering. So let's talk a little bit about why this is a brain disease. First, 1/3 of the risk to develop depression is genetic. A full third. And you know, you can't choose your parents. Sort of a truism. So, you have the hand that you've been dealt. But genes interact with the environment. So what I'd like to show you here on this slide is what are the diseases that have the strongest genetic influence of all of those in medicine. Putting aside mutations in a single gene like hemophilia or Huntington's disease, it turns out psychiatric disorders are the most genetically driven. That's what we need to tell the legislators. They're the most genetic. 2/3 of the risk to develop bipolar disorder is genetic. 50% of the risk to develop schizophrenia is genetic. 1/3 of the risk for depression is genetic. Whereas other disorders have much less of an influence. Most cancers, it's a little bit of a genetic influence, but a lot of it is environmental. It has to do with alcohol and smoking. That's not the case for psychiatric disorders. And Jim Watson, who Scott mentioned, after the genome was sequenced, said this famous quote, "We used to think our fate was in our stars," paraphrasing Shakespeare. Now we know in large measure our fate is in our genes. So where we are in psychiatry right now is summarized on this slide. We know genes are important, but genes, what do? They change cells. Genes express proteins. They're enzymes. They're structural proteins. Some of them code for neurotransmitters. They do something to cells. Now, the human brain is a pretty complicated organ, okay? It has billions of cells, all of which are different from each other. I often wonder, why didn't I go into hepatology, the study of the liver? The liver has 3 cell types. You know what liver looks like. You know what it's like when you eat it. It all looks the same, right? It's that brown, oogie stuff, right? Okay, and you look at it under the microscope, hepatocytes, they're all the same. They're exactly the same. But your brain is so different. The overlying cortex is totally different than your emotional part of your brain. And the brainstem that controls your autonomic functions like heart rate and breathing. So these cellular changes from the changes in genes result in changes in brain circuits that result in changes in symptoms that we call psychiatric disorders. Some people call them clinical phenotypes. Now, the reason genes are important is if you look around the room, we all don't have the same genes. If we did, we would all be clones. We'd all look alike. We have about 99% of identical genome, with each other, but at 1% different, and genes come in different flavors. I'm going to give you some examples of how it can affect you. Don't have too much hubris because we share 98% of our genome with the chimpanzee. So what are the risk factors for depression? Women are twice as vulnerable for depression than men. We still don't exactly know why. And I talked about genetics, but the other big risk factor for depression is early life trauma, child abuse and neglect. And that's because the developing brain is vulnerable to insult. It's vulnerable to lead toxicity, and it's vulnerable to what I call emotional toxicity, physical and sexual abuse. And I've spent the last 30 years of my life studying the consequences of child abuse and neglect on the brain and how that translates into vulnerability for depression. Now, child abuse is a form of stress, and we know that stress precipitates depression in vulnerable individuals. Marital stress, job stress, you can be doing fine. All you know this, you do clinical work. Your patient's doing fine, something bad happens, they're stressed, and they get plunged into another episode. So what is it in the brain? What's going on in depressed patients? Why do I say it's a brain disease? There are neurotransmitters. Dr. Teitelbaum mentioned dopamine as a neurotransmitter involved in the biology of substance abuse. It's also involved in the biology of depression, and I'm going to give you just a couple of examples of this. This is the serotonin system. I'll tell you a little brief side anecdote to keep you alive. My daughter's name, my youngest daughter, is Sarah Francis. When she was a little girl, about 6 years old, she was sitting exactly in a room like this while I was lecturing, and I might have used this slide. And afterwards, she said to me, "Daddy, who's this little girl serotonin you're talking about?" I said, "She's going to be on an analyst couch having a rivalry with a neurotransmitter." Serotonin is a very old neurotransmitter molecule that rises from the lowest, oldest part of the brain, and it sends its axons and nerve terminals everywhere. Okay, so there it is at the lowest part of the brain stem, down here, and it goes all the way up to the limbic system, the emotional part of the brain, and the cortex. And this is one of the nerve terminals of those serotonin neurons, and each neuron gives rise to about 500,000 of these that enter your cortex. And every time that neuron fires, it releases serotonin. And you see a protein that's sitting right there on the presynaptic terminal called SIRT. And SIRT is the protein where antidepressants work, where SSRIs work, like fluoxetine, Prozac, or sertraline, Zoloft, or Lexapro, escitalopram. I always say God made the serotonin transporter so we could prescribe antidepressants and help people. And it seems to work pretty well in many people. What's the evidence there's something wrong with serotonin in the brain? This is one way to measure serotonin function in the brain using some highfalutin brain imaging called SPECT. And right there where it says 5-HTT is measuring the serotonin transporter in the brain. That's a side view. It's not my brain, but it's not a bad-looking brain. And what we reported in this study some years ago is if you look on the right, that depressed patients have a reduction in their serotonin function compared to patients without depression. And this is one piece of evidence that serotonin is important in the biology of depression. Now I want to talk about the issue of gene-environment interactions, because it's really important. And Scott mentioned it in his talk. Dr. Shern mentioned it as well. And it turns out that genetic vulnerability interacts with the environment. So what I'm showing you here is one of the most famous studies that was ever done, and it's been widely replicated. What you're looking at on the y-axis is the likelihood of getting depression. And what you're looking at on the x-axis is a large patient population divided up into no child abuse, probable child abuse, or severe child abuse. And what those three colored lines are different variations of a gene that controls serotonin activity in the brain. Actually, the gene that makes the serotonin transporter that I just mentioned to you. And it occurs, you get one gene from each parent, so it occurs in three possible forms. You could have a short arm from each parent, and that's called an SS. You could have a long arm from each parent, and that's called an LL. Or you could have a short arm from one parent and a long arm from the other, and that's an SL. So what I want to point out to you, because it's just such a fabulous study, is that in the absence of child abuse, it doesn't matter. It does not matter what your genotype of the serotonin transporter is. You don't have any increased risk of depression. But look what happens if you've undergone probable or severe child abuse and neglect. Now it really matters. Because if you have the LL genotype of this gene, you're totally protected. That's a resilience gene. But if you have the SS genotype, you have a very high likelihood of getting depressed. We've identified about 10 of these genes. Our group has identified about 4 or 5. Others have identified other genes. There are about 10 genes and their variants that control the likelihood of you becoming depressed if you have been exposed to child abuse and neglect. And this is sort of the future of where psychiatry is going. I just want to mention a few other neurotransmitters, talk a little bit about treatment, and leave time for questions. Here are the dopamine neurons in the brain, and most of you know about dopamine because it's involved in Parkinson's disease, but it's also involved in a number of other brain functions. And it's clearly involved in depression. And this is a summary. I'm not going to go over it with you. There's lots of data, but I'll show you one piece of evidence. What you're looking at here is a study from the University of Toronto in which an investigator named Jeff Meyer measured the number of dopamine binding sites, transporter binding sites, which is a measure of the number of dopamine neurons you have in your brain as a function of your age. And sadly, you'll notice that in the solid line, which are normal volunteers, you have a lot of these dopamine transporters at age 18. You see it's about 5.0 is the measurement. And then over time, as you get towards 55, they fall. That's why there are no 55-year-old tennis pros, incidentally, because you lose your dopamine neurons, and that's what you need for really fine motor coordination. Okay, that's a sad thing, That's a sad thing. I went to the Atlanta Braves fantasy camp about 5 years ago. I played high school, a little bit of high school baseball. My wife got it for me as a gift. I can't hit a fastball anymore, okay? But it turns out it's not my fault. It's the dopamine neurons, okay? The dotted line are depressed patients, age-matched. Look at every time point. They have fewer dopamine neurons than do the normal volunteers. So dopamine is yet another neurotransmitter, and it almost certainly mediates the ability to experience pleasure. It's why it's involved in drug abuse. You turn dopamine neurons on when you take drugs or eat a great meal or have sexual pleasure. But unfortunately, when dopamine is awry, when it's not available, you really lose the ability to experience pleasure. So we've not only been able to identify brain areas which show abnormalities when people are depressed. As you can see here, this is a technique called functional magnetic resonance imaging. But we've been able to show what antidepressants do, and they actually have an opposite effect to that depression has. And we've even been able to show that psychotherapy, shown at the bottom, and antidepressants act in different ways. To be sort of crude about it, antidepressants work from the most primitive parts of the brain up and affect your cortex, the thinking part, psychotherapy works from the top down. It affects your cortex, which then gets your limbic system, your emotions, under control. A very famous neuroanatomist at MIT once said that the problem with psychiatric disorders is that the cortex has too loose a rein on the limbic system, on the emotional brain. And there's something to be said for that notion. So let's talk a little bit about treatment, and then I'm going to stop, and I'm looking forward to taking questions from you. I'm going to show you a little bit about sort of the future of certain treatments. We have some good treatments. They're listed here. There is evidence that each of these treatments work. Psychodynamic psychotherapy was originally based on Freudian notions, and there's actually a small but significant amount of evidence that that therapy can be effective for certain patients. There's a lot of evidence that cognitive behavior therapy and interpersonal psychotherapy works. Electroconvulsive therapy, we just opened a new ECT service at the University of Miami Hospital. It's the most effective treatment without a doubt. Lots of stigma about it. You know, One Flew Over the Cuckoo's Nest was a great movie, but it sure caused a lot of mischief in terms of getting treatment to people who really needed it. And light therapy works for people who live in the Northeast and in Minnesota and in Sweden, and you know, they ought to just move. Okay, now, and there are a lot of antidepressants that work, and for antidepressants, if they don't work, there are bunches of medications that you could add to antidepressants that will make them work better. And that's the topic of a whole nother presentation. I'll answer questions if you want. I did want to talk a little bit about some new treatments. So the FDA approved vagus nerve stimulation for treating refractory epilepsy in 1997, and it was quickly agreed upon by third-party payers to pay for it. Both Medicare paid for it, as well as Blue Cross, Aetna, and all the other payers. In 2005, it was approved for very severe refractory depression, and nobody will pay for it. Now, if that isn't an example of stigma, I don't know what is. We're going to pay $35,000 for someone to have this if they're having a seizure, but if they're suicidally depressed, we're not. Okay, I went to Medicare in Baltimore to argue the case, and you know, obviously I didn't do a very good job. It fell on deaf ears. Rapid transcranial magnetic stimulation was approved 3 years ago by the FDA for the treatment of depression in patients who failed one, but not more than one antidepressant. I don't particularly like the business model that has been developed by the company that has manufactured this. I think it's greedy. It costs $5,000 a week for 5 or 6 weeks. It's also not covered by insurance. So my colleagues at the University of Florida have purchased this device. I'm boycotting. I'm not going to do it. I think the evidence isn't that compelling. I think ECT is far more effective. I'm waiting to see what subsequent trials show. The company needs to pony up and do those trials. The most exciting finding in depression treatment is deep brain stimulation. This is not going to be a universally available treatment. It's going to only be done at specialized centers. There is an area in the brain called Brodmann's area 25, or the anterior cingulate gyrus, and it turns out that implants there with a little stimulator have been life-saving in very refractory patients. I started this program at Emory. We now have this program at the University of Miami. It's expensive, but it's absolutely life-saving. And I think you'll hear more and more about that. So there's the view from Key Biscayne, 10 minutes from my office. I use that when we're recruiting. You've been a great audience. Thanks very much.
Charlie, that was a fantastic presentation. I think you can start to see some of the thematic similarities that are starting to emerge in terms of what we're coming to understand about the developmental sequences that cause people to become addicted or to cause them to develop mental illnesses, that the Gene Caspi's work that shows the gene-environment interaction is very powerful in terms of understanding what probably regulates genetic expression in some ways. This is the whole field of epigenetics, which is nothing I had ever learned in school prepared me for epigenetics. Very, very exciting times, and I think you can see the science is really solid. We're going to take about 5 minutes of questions. Remember, we'll be back later for an open back and forth, but I've been warned that the beverages go away at 3:30, so we don't want to lose our beverages. So why don't we ask a few questions for Charlie, and then we'll take a break.
Sure.
Doctor, I noticed at the outset of your presentation you talked about looking at schizophrenia very closely in your practice. While you didn't speak on it, I was very interested to get your thoughts on the prevalence of depression in patients with chronic symptoms of schizophrenia who also have co-occurring medical conditions. And then also, in tandem with that, perhaps maybe you could speak to the issue of patients with schizophrenia who are also forensic and the prevalence that you've noticed with depression in that population.
Well, I think first, the presence of depression in patients with schizophrenia was first reported by a fellow in New York named Sam Cirrus. And he first reported it after the initial episodes of psychosis. After it got under control, a number of the patients having gotten in touch with what was going on in their life became quite depressed. There are a very limited number of trials of antidepressants in patients with schizophrenia. If you actually look at the data that's available, there are virtually no controlled clinical trials, and those that have been done have not particularly shown a robust antidepressant effect. However, more than 50% of schizophrenic patients at any given time are receiving antidepressants. So clinicians believe that antidepressants are helpful for patients with schizophrenia. One of the foci that we have right now in schizophrenia research has to do with issues related to functional capacity and functional recovery. And that means treating the whole patient. In the old days, we were just pretty satisfied that patients with schizophrenia weren't hearing voices anymore. But that didn't get them back into the workplace. And so what we're now working on very substantially is, and if we had the resources, it would be a little better, is vocational rehabilitation, group therapy. Other countries do such a better job than we do. Exercise. These medicines have side effects. They cause patients to gain a lot of weight. They develop secondary diabetes. Patients with schizophrenia, depression, and bipolar disorder are at higher risk for heart disease, stroke, diabetes, cancer. They have higher rates of cigarette smoking, etc. Now, the forensic issue is really complicated. All of you I know Judge Leifman and the work that he's done in the state of Florida trying to prevent the jails and the prisons from becoming psychiatric hospitals. Because the fact is that at those settings, patients can't get really good care. So, the issue is very simple. If a psychotic patient commits a crime, and we're not talking about an insanity defense that's frivolous. We're talking about somebody who really has poor judgment because they know not what they do. It makes no sense for them to be incarcerated. It just doesn't. And it's tough saying that in this climate because the pendulum is swung away from that notion. I could safely say it in this room. But, this is yet another form of stigma. And, we have to do everything we can to fight against it. Yes?
You talked about the future and improved treatment matching. What do you see as, the matching of medications to genotype?
Yeah, I was just working on a paper that we've identified a couple of genes. We've published already on several genes that predicted response to citalopram, Celexa, and we're now looking at genes that predict response to other antidepressants. I think that's where the future of psychiatry is, but we have to get away from the notion that it's going to be a single gene. Okay, one of the ways we got into trouble in psychiatry was because of the high genetic contribution to our disorders. Geneticists flocked to us thinking they were going to win the Nobel Prize by finding the gene for schizophrenia or the gene for depression or bipolar disorder. And it turns out that these are complex diseases for which multiple genes each have a small contribution, but together they bring you to threshold. So that there are probably 10 or 15 genes that together determine whether you're a responder to antidepressant A or B, and probably whether you're a responder to psychotherapy also. So no question psychotherapy is a biological treatment. I mean, we know that. So, I mean, it's a form of learning. So I really think we're going to get there. I hope we get there before I move on to the next life, because it's really exciting. Yes, ma'am.
I'm curious to know if you've looked at diet at all with respect to prevention. I was seeing research that showed that countries that have high levels of omega-3 in their diet have significantly less diagnosis.
Right. So the question has to do with diet, and particularly omega-3s. And, you know, omega-3s, my long-gone mother would make the analogy to chicken soup. She'd say, you know, it can't hurt and it might help. So the data on omega-3 is exactly what you said. Countries with very high ingestion levels of omega-3s do have, well, number one, much less heart disease to start with, which is a good thing. And there's some evidence, not as great, that they might have lower levels of depression. The treatment studies with omega-3s are dicey. So for people who take omega-3s, you know, because you know, omega-3s are sold not as drugs but through the health food store. Number one, the quality of the tablet is not regulated as tightly, and so when you do trials, you have to use a particular high-quality brand, and there's just not enough evidence yet. I'm agnostic on the issue of what works. Okay, I'm willing to keep an open mind about any treatment that's going to help our patients. I just demand that we have to use scientific principles to get there. And, you know, there are charlatans in our field. You know, I just saw a patient, Scott was talking about the $75,000 assessment for drug abuse. I just saw a VIP patient who in Los Angeles was seen and charged $50,000 to get scans. And the report, I read the report, said, oh, because you have this pattern, you'll respond to this drug. And it also suggests you have thyroid disease, which, you know, you actually need a lab test to diagnose, like a blood test. So, you know, unfortunately, you know, the Internet, it unfortunately is a double-edged sword. And you get a lot of bad information on it. And so I've had patients say to me, I'm not taking those synthetic chemical antidepressants. I'm going to take St. John's wort and kava. And, you know, that'd be great, except there's no evidence that they work in severe depression. But we have to keep an open mind, absolutely. Yes?
Since drug abuse and depression both are involved with serotonin and dopamine, are we missing the fact that maybe many of our drug abuse patients are self-medicating and missing the opportunity to give them antidepressants which might help them make that transition from drugs of abuse to drugs that are
Yes, so the answer is yes and no. So if you take 100 cocaine abusers and you bring them into the hospital, they're all depressed when they come in. I guarantee it, okay? And what happens, though, is that after about 2 to 3 weeks, about 70% aren't. And they really don't have concurrent depression. They were depressed because they were angry about being in the hospital, and, you know, and they're not getting their drugs, and they're irked. The 30%, though, really have a comorbid depression, and that's gave rise to dual diagnosis units, and those patients really need to be treated. But there have been a number of trials looking at whether antidepressants in the cocaine population reduces cocaine craving, and the answer is it doesn't. So it's only effective in people who are, in fact, depressed. Yes? Yes, ma'am.
Is there any data that speaks to loss of weight or dieting triggering depression? I've had 3 episodes of severe depression, and all of them have been after an episode of weight loss.
Okay, well, I'm first going to say that I'm not going to go on the crash diet that I was going to now, okay? So I needed a reason. Thank you. I'm going to go eat a piece of pizza, okay? So there is a very high rate of depression in patients with eating disorders, in particular in anorexic patients, extremely high. The rate is something like 85%. And so very rapid loss of body weight can actually trigger an episode of depression. We see this all the time. So I'm not surprised about that. You look pretty fine to me.
Why don't we take a break?
Okay.
We have time later. We work with Tom Insel, quite a bit. I know you do. Yeah. And Chad. Yeah, and so we know a lot of people who love to do this. It really sets up how you did. And then my friend and colleague Gail Hutchings, who is one of these absolutely set your watch by reliable people, who said she has never had to do this before, unfortunately really was too ill to travel. And so I was asked to sort of step in for her at the last minute. So I'm going to do the best job that I can in terms of talking you through her slides. Most of the stuff in the slides I'm familiar with. So, what you're going to see is there's some really consistent themes emerging now. You know, with this last talk, we're going to shift more to a systems perspective. The first few talks, we really kind of talked about some of the basic neurobiology and some of the ways we think about these conditions. You know, and sometimes we're our own worst enemies in terms of not really understanding the fundamental scientific basis for our work. And I think that's